Good afternoon, everyone. My name is Anjali George. I'm one of the facilitators with the Stroke and Neuro Rehab Network. Welcome to our webinar on implementing blood pressure at home in community stroke teams across Greater Manchester. Just a few housekeepings. There will be a live Q&A session at the end. Please ask your questions in the Q&A box and we will facilitate the discussions. The recordings will be emailed to you afterwards, and if you require any certificates, please contact Lisa. At the end of the webinar, we will be asking you for an evaluation. Follow us on Twitter at GMNISDN and feel free to tweet about the webinar. For future training events, see our website. I will pop up the link on the comment box. For any details or questions, please contact Lisa. Thank you all for joining, and without further ado, I hand over to our speakers, Carolyn and Louise.
Hello, welcome to the webinar. This is about implementing blood pressure at home in community stroke teams across Greater Manchester. My name is Louise Worswick. I'm a clinical lead nurse for the GMNISDN, and later you'll hear from Carolyn Shimwell. She's a clinical lead for the network. She's got a community stroke role. So we know that NHS England blood pressure monitoring at home initiative was launched in response to the COVID-19 pandemic, and this was in late 2020. It had an aim that was to support patients with poorly controlled hypertension, being able to have access to local services to understand what blood pressure readings were about. From a stroke point of view, we know that patients who've had a stroke have a 20 to 25% chance of having a further cardiovascular event, especially within the first few weeks of their stroke. So why would we want to get involved in the project? Well, our aims are clear. Stroke risk factors and prevention post-stroke look at blood pressure readings and blood pressure management. And although we didn't know how the GM teams currently did this and to what degree within the local areas, we do know that the research indicates that home BP monitoring is a much better indicator of long-term morbidity and mortality than clinic readings. We also know that unnecessary hypertension and antihypertension treatments cause complications and can cost, thereby being avoided this. So why do we want to get involved? Well, stroke risk factors and prevention post-stroke look at blood pressure readings. Although we didn't know how the GM community teams were currently doing this and to what degree within the local areas, we do know that research indicates that home BP monitoring is a much better indicator of long-term morbidity and mortality than clinic readings. We also know that unnecessary antihypertensive treatment and its complications and costs can be avoided with at least 10 to 15% of the population who have a normal BP at home but an elevated clinic BP reading. This is known as white coat hypertension. And also, whilst facilitating appropriate treatments in others whose high home blood pressure readings attend clinics and their reading is normal. This isn't detected in a clinic setting and is called masked hypertension. The aims for the BP at Home project within GM are on your screen, and they're quite clear to see that we're interested in reducing the number of deaths or stroke and heart attacks associated with high BP readings. We're looking at gathering readings with a more reflective BP in a more relaxed environment, and within our local areas we use the home setting. So the overview within Greater Manchester, we have 10 community stroke teams that participated in this event, and it started in February 2021. It was led by stroke specialist nurses with full MDT support within the areas. We was given a supply of basic monitors and also monitors that had the ability to look at AF detection. Some teams received a range of cuff sizes that were different from the standardised ones given with the monitor. And we asked patients to take a twice reading per day in the morning and twice reading in the evening. We know that community stroke teams work with patients to help modify the risk factors, including hypertension across GM, and that patients under the care of the community stroke teams usually receive multiple visits following their discharge home. providing this was the perfect opportunity to implement BP management, self-management and reduction programmes for hypertensive stroke patients. From early 2021, participating teams in the region identified patients from their caseloads using a set inclusion criteria. Patients who had a BP reading of above 130/80 and a history of stroke were included. This was our inclusion criteria. We do know that if patients had carotid stenosis with an increased guidance of 150, we wouldn't obviously include these in the project, but stroke and a BP of 130 was the basic inclusion criteria. On the screen is the clinical guidance of the blood pressure. When we look at stage 3, if we come across these patients with these consecutive BP readings, when asking to monitor, we inform them they should repeat a further 3 readings after sitting quietly for half an hour. And if their BP at this time was still elevated, we would see it as significant hypertension. And therefore they should contact their GP immediately for an urgent same-day appointment or assessment and investigation. So what were the enablers for the successful implementation of this programme? Well, there was network-led meetings and the network linked with the NHS England and Public Health England platforms to be able to receive the equipment that we would require, to source the equipment and to distribute it appropriately to the GM teams. They also engaged with clinical lead cardiologists, and Dr. Philip Lewis supported the education and created 2 YouTube videos for the team within GM that they could access to support their knowledge. This was a great resource teaching tool, and people can now use this and access this on YouTube for anyone else that would like to use it. Local data was collected by the teams, but it was sent to the network data specialists for inputting into the graphs and data that we'll see later. Again, this enabled the successful implementation and review of the project. We had peer support. We used Microsoft Teams for this. It allowed regular contact with peer support, and we had this technology pre-COVID, and interestingly never used this feature to connect across the GM platform for peer nursing support. However, now we have used it and we have utilised it furthermore within multi-peer situations, including further prevention work and further ongoing work of the BP at Home projects following this project. We also use it as a support for wellbeing and to identify peer review. So the clinical practicalities of taking and collecting the readings. Well, we asked for an initial assessment. It was taken by a clinician on entry to the home environment when completing initial assessment. If the BP was out of range at that point, they were offered the BP at home monitoring, and the patient was issued with a monitor, recording sheets, instructions, training on how to use the equipment we'd left. We also used alternative sources, i.e. carers, family members, friends, when the patient wasn't able to do it themselves. They took a baseline reading and it was taken for 4 days, and it was averaged by the clinicians after 4 days. Those baseline readings were taken twice in the morning, pre-medication, and twice in the evening. If the home reading was within the normal range, within the guidance that we was looking for, the patient was taken off the programme at this point. We didn't continue with them. If the home readings, once averaged after 4 days, were out of the range, the action was taken by the community stroke teams to give this information and to provide this information to primary care centre GP practices, and that would allow support with potential actions that come from it. If, for instance, the GP or primary care providers decided to increase medication at this point, there would be, the patient would receive the medication, they would start the medication, and we would wait 2 weeks from the date of that increase in medication. After 2 weeks, we would then ask them to repeat the cycle, and they would complete 4 days worth of 2 in the morning and 2 in the afternoon readings again. Then after the 4 days, the clinicians would average it out and we would reassess the numbers and whether they was in the guidance or whether we needed to complete more action or more help or support from the GP or the primary care providers. We continued with this cycle, and this went from 4 weeks to 6 weeks to 8 weeks, and it stopped once the BP was in normal range. There was also alternative reasons for this stopping. This might have been that the patient disengaged, the patient was readmitted to the hospital, etc. The results were collected either at home visits or over the phone. So the home visits was the preferred method for most stroke teams, although we did, like I say, use telephone. Patients didn't prefer to email or text their results. This was normally verbal telephone conversations. This was due to having lack of technology, lack of understanding of the technology, lack of confidence with wanting to utilise numbers or give numbers or readings, and they was more happy to be able to discuss these verbally. We do also know, though, due to stroke impairments, that some people would have preferred to have written down the numbers or to have given them via a carer or another member to support this. At the home visits, as teams were going anywhere, they was normally in the property throughout the week at different times, and hence why different members of the MDT visiting could also provide support and understanding of these measurements. It wasn't just one person, it was a team approach that collected this information. So benefits of the BP at Home project within GM. So there's several on the screen. We know that it supported nurses' key role within the prevention and other team members utilising their experience or their skills or upskilling them. We utilise assistant practitioner roles within the framework of the education and competencies they have, also TIs and other members within our teams. We improved communication with GPs. This was one of the common themes across GM. We created a template letter which identified the actions and the rationale. So when communicating, we was clear and we made identifiable communication that supported a request or an action being able to be implemented or being able to be understood, the reason of what we was wanting, to provide support for the GP to enable the assessment or the action with the patient to be clear. We also try to incorporate codes, clinical codes that would support primary care centres such as the SNOMED codes for BP at home monitoring by patients, so giving them useful data which they may choose to use. We also know that patients improved compliance with medication because of the project, because they had a better understanding or could see an action because of their medication and the way that they took their medication at the appropriate time, and they repeatedly took it. So this proved beneficial for the compliance and administration of medication. We also know that we reduce the risk of potential strokes due to the number of people that we managed to get their BP readings less than 130 over 80, so therefore it was within the guidance. So the staff comments on the screen, all of the staff across GM that were involved in this speak very highly of it. Their ability to focus on a topic, especially one linked to prevention and the reduction of stroke, and have education be given to them and applied to them, and supplies of monitors, machines, cuffs, etc. All of those timely interventions across the project give a direct impact and involved with their patient care, and they could see clear results and clear impact on their abilities to educate and upskill not only the workforce within their teams, but also patients and carers, family members and the wider community. So we've told you clinically how we went about this and also what the staff thought. This is a patient story. He was a gentleman that was 44-year-old. He was married with 2 children, a full-time worker pre-stroke, and he was discharged from a local stroke unit into the community stroke team. We completed his reading on initial assessment, and it was 154 over 76 manually. At that point, we fitted the inclusion criteria, and therefore we give education and a machine and support for 4 days of home monitoring And after these 4 days, his average reading was 159/78 using the BP machine. Therefore, we decided to give this information to the GP, and the GP actioned, again with the template that we'd sent them and the rationale and the information supporting it. They completed an assessment with the patient and increased the medication that he was currently taking and titrated it up to the next dose of antihypertensives. We waited 2 weeks from the date that he took the increase in the medication, and then we started again the 4 days of home monitoring. And 2 weeks later, we know that that BP reading after those 4 days was 125/75. His BP is now in stroke guidance, and as you can imagine, we're extremely pleased with the results and the interaction and the intervention that we was able to have on this patient to reduce his risk of stroke and prevention in general. So the aims at the beginning that we described about the project, this showed we managed to complete some of these within this story. This was about reducing the number of deaths or potential strokes and restrokes with 20 to 25% chance of having another event within the first few weeks of stroke, like I explained at the beginning. The gentleman was able to gather his readings that are more reflective of a BP that is taken in a relaxed environment at home, and it provided a reliable information to the GP to be able to make a decision on his treatment. And also we know it enables the patient himself to monitor his BP and to have some understanding and self-awareness in the longer term of his own health. This is a successful basic example of a 2-week cycle, and when we completed the post-intervention, it shows its success again. Later you will see that this patient reflected within the 54% of the patients on the caseload at 2 weeks, and then they leave the programme. They have no further need for us to see them to have intervention. We know that this intervention was less than 21 days, and it had a significant impact to prevention and health. On the slide, this is a description of the patient's experience. He references this machine being easy to use. We provided it. He knew how to use it once we'd shown him. It was simple. He didn't have to travel or go to a hospital or to seek GP attendance at his local surgery. All of his intervention and interaction occurred without him having to leave the house. We know that he was pleased that the results were sent to his GP and that an appointment was made for him to discuss the medication within a timely manner. And we know that he previously had difficulty contacting and being involved in his primary care centre, and therefore he was pleased with the support that we were able to give directly to the GP surgeries. We did this support and direct information exchange normally through email, through .NET accounts. This was an example of an able patient that could complete this independently, and we achieved our primary goal of his BP being within the stroke guidance. We also know that the patient, being the person that understood prevention and utilised the newly learned skill, was able to identify his own health and his own impact of that going forward. We will see on the next slide that there are other patients that were less able to do this, and that they had different types of impairments that didn't allow them to be independent. However, we know that with support, they were able to complete monitoring of the BP at home. This is still possible, and this is still possible to have as an assessment and as an intervention with different options of support. We will also show you the data of the slides that will be explained by Carolyn, and this also will include identifying the phases, baseline readings and intervention, plus the subsequent 2-week results of the 168 patients that we managed to place on the project.
So thank you to Louise. My name's Carolyn. I'm an occupational therapist by background. I lead the community stroke team in Rochdale in Greater Manchester, and I'm the clinical lead for community stroke in Greater Manchester as well. You might be wondering why an occupational therapist is this involved in blood pressure monitoring, and the reason being is that I did a master's, and one of the modules was on health economics. So because I lead a stroke service and stroke prevention is key to the health of our patients, I focus that on blood pressure and trying to manage blood pressure and develop pathways within my service. So that's where my passion for blood pressure management came from. So I'm going to carry on talking through the presentation now. So we're moving on to the demographics of the cohort that we're looking at. So we wanted to look at who provided the readings to see how sustainable it was within stroke teams, and we found that 58% of the readings were taken by the patients themselves, which is really positive for us. 20% were then taken by the carers, and 16% were then supported by the stroke team. And then there was other people as well, but mostly it was either the patient or the carer. So we're talking 78% were actually from the patients themselves, and that's really good. And it addresses the issue with white coat syndrome, because if we're still going into most of the patients, or the nurse is still going into most of the patients, actually the white coat hypertension remains. So by the fact that most of the patients would either them or their carer doing it, that does put them in a more relaxed environment at home. Looking at which is not on the graph, we had 63% males and 37% females, which looks like it's skewed, but that was the population that we had at the time. We also looked at some ethnic background data, and over 90% were white British, which actually doesn't necessarily reflect some of our population in Greater Manchester. But we can't further analyse that because it wasn't a research project. Just looking at the age of the patients as well, which is on the pie chart, 21% were under 50, 28% were aged 70 to 79, and 25% were aged 60 to 69. And then we've got a 13% aged 50 to 59. So it really varies actually throughout all of the age groups. We only had a few in the 90+ bracket. This graph shows the different phases of blood pressure. So starting with those accessing the scheme with the out of range blood pressure in the first column, obviously 100% of patients were in that because that's the baseline reading. By the second column, which is 2 weeks after medication change or intervention, should I say, only 54% of the patients still had blood pressure issues. So indicating that 46% were then within normal range. These figures dropped over time, and as weeks progressed, the patient's blood pressure came under control. And so we've got baseline 2 weeks, 4 weeks, 6 weeks, then 8 weeks. In 8 weeks, we only had 1% of patients left in the programme. So readings over time. So an initial assessment, we can track the previous graph. So initial assessment, average readings at each stage. You can see the average drops over the first 3 cycles. However, the last 2 columns show an increase in the readings. This is due to the length of time needed to get their BP under control, suggestive that those patients were actually the hardest to manage due to things like comorbidities, or they had to their readings were that high to begin with, that the medications needed titrating slowly and carefully within safe limits. So if we look at so we've got initial baseline 2 weeks and 4 weeks where we can see it coming down and down and down, but probably those at the 6 and the 8 weeks are the ones that were very, very high to begin with. So this is a graph that shows the results after baseline at home monitoring. So these patients are those that no longer needed intervention just by having a monitor given at home. So what we need to look at is the horizontal axis at 0.0. And that line would indicate no change in blood pressure from the initial reading taken to the baseline readings that they did at home themselves. Therefore, anyone below 0 indicates a reduction in blood pressure from the initial reading, enough to receive no intervention. So it is worth noting that many of these patients were likely to have commenced on an antihypertensive medication in hospital, and actually it's taken effect. So we can't just attribute it to home blood pressure monitoring. However, it did give us an indication that we didn't need to do anything further and that they could come off the scheme because the blood pressure was under control, unlike when we first put them on the programme. We also analysed the over 80s within using the same system, and just to see if there was a different trajectory, because the different guidelines for over 80s, and actually they did follow the same trajectory and improvement, so we haven't included the graph because it was pretty much identical. Those that remain above the line of 0, so actually their blood pressure's increased. Some of the ones at the bottom end, so the very first dot in the top left corner, their blood pressure started off low, and we've got it to roughly 105, so we probably wanted that to go up, so we may well have stopped an antihypertensive, or something such as that might have happened. It's hard to know on an individual basis. Some of those at the other end of the graph, so above 0, but in the right hand side, where it's above 160 and gone up, I assume they've been non-compliant in the scheme, because otherwise we would have continued them on the programme. So it's hard to know without looking back at the exact piece of data why they didn't carry on, but the most likely is that they were non-compliant. So after 2 weeks of intervention, we've looked at those patients. So the previous slide was ones where we did nothing because the home monitoring showed improvements in itself. So this is after 2 weeks of intervention, which might be GP change medication, it might be lifestyle changes, or most likely, in most cases, it was a change in antihypertensive medicines. So again, we're looking at that horizontal axis at 0, where no change would have happened if they were still sitting on that line. So anyone under that line has had a reduction in their blood pressure. So if we look at the bottom right hand side, so those two will have started off with blood pressure at well over 200 systolic, and the first one has dropped by around 70 systolic, and the other one's dropped by more than 80, so actually come down to a normal range in only 2 weeks of changing blood pressure medicine. So I think that's quite a significant change in a short period of time, actually. But obviously their risk of re-stroke, etc., is reduced enormously over that time, over such a short period of time, and shows that the interventions are working really well. Okay, some of the challenges that we faced, we thought we'd talk about this. Initially, it felt like a huge change in service delivery. However, as we got used to the data collection tool and actions that we were doing and letters that we were sending out, etc., it did become kind of normal practice, and we had lots of training, and it's become second nature now, realistically, for the whole team, not just the nursing team, and it gives us a really clear pathway now for blood pressure management. A further challenge came once the supply of monitors from Public Health England stopped, and it's around now working out how to access more monitors. So none of the services wanted to stop delivering the BP management, BP at home, and this is because of how positive the results are. It's just clear that it's something that we really need to continue. The idea was that patients can self-monitor, and as we know, many physical and cognitive issues stroke patients face mean it's not always going to be possible. However, it was possible for 58% of the patients and a further 20% of families and carers, which is quite a significant chunk of our patients, actually. The next things we're looking forward to doing, so next steps are we're looking at publishing the results, so the full results, in journals and at the UK Stroke Forum. We're hoping to have a presentation accepted there, or a poster accepted there. We now have a cardiovascular disease prevention lead within the network, and we're working with him on improving primary and secondary prevention of stroke. We hope all teams have now embedded this into current practice and have written a shorter report for leads of those services to take to commissioners, because the numbers speak for themselves. It is clear it works. It's relatively cheap. If we're thinking sort of around £60 a monitor, that actually you can reuse. You don't have to leave them with the patients necessarily, and that will increase the longevity of the service running. So we are looking at commissioning further monitors within the services. If anybody would like to know more about blood pressure itself and best practice on how to take readings, etc., then we have 2 webinars from the expert that supported us throughout this project, Dr. Philip Lewis. So he's been involved in the national programme for rolling out BP at home, clinically leading that, and honestly the 2 webinars are brilliant and would really help anybody looking to implement this into practice. Things like the cuff sizes and the way it's taken, etc. There's a lot more to it than even those of us who were already taking blood pressure, etc., realised, and it takes an expert like that to help you understand that. So well worth a watch if you'd like to. And that takes us on to any questions.